Thank you, Andy, and thanks for inviting me. It's really nice to be back home. I like to say that even though I've left Ann Arbor, I'm still a very loyal Wolverines fan because my younger son won't let me forget that. So we're pretty obsessed about following and saying "Go Blue" every Saturday. All right, so what do I do here? Somebody, is that mine? It is or it isn't?
It's not.
No. Well, I'll tell you a joke. No. No, I'm actually very honored to be on the same stage with John and Jeff and other distinguished speakers. You've all been disclaimed and my conflicts have been disclosed. So we can move to the next one. Oh, how do I do this? This way? Okay. So what I'm going to do today is to talk about one portion of what in this discussion of learning healthcare systems, which is not just what we commonly think about, which is big data, and when we hear big data, we think about more observational use of data, but we in medicine, obviously, we really like randomized trials. Randomization is like magic. It does all sorts of things. The person who does it doesn't have to be particularly smart, but if you do it, it gives you really, really great results. So it's like discovery of fire or whatever. It's one of these major achievements in human intellectual history, I would say. So we still want to use that, even in a learning healthcare system, in prospective clinical trials. And the idea is to do it within a pragmatic trial, and I'm going to talk about that. So what I will do is quickly talk about why it's important to do that and the kind of ethical tension it raises. I will lay out the options of resolving that tension and then speak very briefly about how would you do that. So I'm going to give you the possible solutions first and then, or results, and then talk about how one might get there. So I'm not going to spend a whole lot of time on this because the emphasis on the pragmatic ideal is so prevalent within, I guess, modern medical culture in the States that it's not good enough to have drugs that we tested in a small group of people. And we think it'll work in people who are 80 with diabetes and hypertension, but we never tested it, but we're going to do that. So we want to be able to avoid those kind of questions by testing it broadly in a very realistic way. And you can summarize it by saying that we want to do research that closely mimics the usual clinical operations so that your answers can be very useful to policymakers as well as clinicians. And of course, this goes with the kind of thing that those articles that Ray mentioned. Some people feel that by doing this, well, maybe we have to worry less about this distinction between research and clinical care, the ethical obligations of each. I happen to think that there is something to it, but we don't want to go too far thinking that way. So these trials are very important because we have many treatments in medicine and procedures that are A or B. Let's call them A and B. They're both pretty good. There could be more than two. Not knowing which is actually better, and it's reflected in the variations in practice and lack of consensus in the field. And these are very valuable clinical trials to do because, when I wrote this, B is new and it's 100 times more expensive. That was kind of meant to be a real exaggeration, but you all know that's not an exaggeration, right? It could be even more than that these days. One of the treatments could be very burdensome, but it could be also more effective. We don't have great data, but that's a suggestion. One might have all the rigorous data, but a clever company has marketed much better a very similar drug, so it's convinced the doctors that it's kind of the same thing, so people use that more than the drug that's actually used in clinical trials. That happens. And then this applies to procedures, surgical and otherwise. And there are many instances in medicine where still we do things because we've always done it. And, you know, like in the 60s, there was that one old study that showed that, and then we kept on doing it, kept on doing it. There have been some new studies, but we're not sure. We really haven't done a rigorous head-to-head trial. So it would be wonderful to know this. And, of course, from a policymaker's point of view, you can save lots of money if you really know which is better, and you do that first. Okay. So what's the problem? That all sounds terrific, right? And you can see why in a learning health system of the future, I'd say, if you can integrate the research and the clinical procedures, you could really come up with very usable data. Now, the problem is that the vision of this system, and you know, if I were designing a place where I could do these randomized trials, you would want to build it into the very framework of the system. So you have a program of series of trials, not just one-off, because you have, hopefully, have set up a wonderful electronic health record system so that you really only have to use that for a lot of these outcomes. However, the problem is that if you required to obtain traditional informed consent with those 10, 20-page forms, you have to sit down and have a conversation. It's really, it's not really conceivable how you could integrate that into the everyday clinic. You know, when I talk to my wife and goes, you know, couldn't you just take 5 minutes? She's a primary care pediatrician, so I said, you know, couldn't you do research? Just take 5 minutes and talk about the research study. And she thinks like, what are you talking about? It's like we're seeing 30 patients a day. It's like, you know, it's chaos. I mean, how are you going to do these kind of consents? So that's one of the most commonly talked about. And that's what I'm going to address today. All right. So here's this intuition, though, maybe standard of care RCTs. And I want to say at the outset, I'm using standard of care RCTs as my shorthand. Other people might want to call them RCTs of accepted treatments, whatever. So let's just, I don't want to get into a whole debate about whether it's the right terminology. All right. But it has these features, right? The interventions are accepted, so-called standard of care. You can't blame the doctor for using it. Everyone will receive these treatments, whether you're inside the trial or outside the trial, right? What most doctors would say, yeah, that's what you do. And there's no special research measures if we've gotten to the point where the electronic records can really give us good primary outcome data. So, again, there's a strong intuition that the ethics of studies must somehow be different than usual. The question is, how different is it, right? Now, here's what I think is a nearly exhaustive list of options that we have. So when we determine whether in a proposed study, it's, number one, it is ethically acceptable to forgo or modify traditional informed consent. Let's say that's one option, right? That's the tension we have to, so we go one direction. So if we do that, and after thorough analysis, these are the kind of options we would have. This sub-list isn't exhaustive, but it gives you a feeling. You could use a shortened form, hoping that that will speed up the process and make things adequate enough. You could do a simplified opt-out. This is kind of specified in the recent European directive, the regulations for clinical trials, in which they do say for certain types of cluster randomized trials, you could do what amounts to essentially a verbal opt-out process. So after you inform them of the elements of informed consent. You could do a verbal consent. This is something that shorter verbal consent. This is something I've advocated for certain types of trials where after certain conditions are met, you could do that. And basically the idea is, you know, I'm a psychiatrist. I talk to patients and I go, well, we could try this drug. This is why I'm doing it. These are the potential side effects. You really don't need to take a lot of time to explain it. And I just document it in the electronic medical records. Or others have advocated, no, even that takes too much time. We can't do these trials using that. So what we can do is to massively advertise this, trying to create some cultural change. The convention itself gets changed so people accept general notifications and broad consent when they join the learning health system, right? You could do that. Or some people have argued, well, you know, some of these studies are so benign that you don't even need consent. Now, on the other hand, suppose you say it's not ethically acceptable to forgo or modify traditional informed consent. Then what do you do? Well, you have a couple options there too. One is you could modify the trial, and maybe you'll be able to modify it to the extent to accommodate informed consent. And it's not what you wanted to do, but it's pragmatic enough. That's possible. In fact, I know that happens, all right? The other option is, well, you know, it's great if we could do it, but if you can't get informed consent, looks like you either can't afford to do the study, or the scientific data you gather just isn't going to be worthwhile, so you can't do it. So I believe that this represents a nearly exhaustive list of options. But how do you get there? You know, I said after careful ethical review, you could go to those options. What does this careful ethical review consist of? Well, currently we do have, for not FDA-regulated clinical trials anyway, these criteria called waiver and alteration. I said foregoing or modifying. So waiving or altering the criteria for informed consent. And these actually, I believe, after having thought about this and written a couple papers on it, it's really uncanny that people who wrote the Belmont report, it is somewhat dated, no doubt, but it's kind of uncanny how thoughtful that document and the regulations that came out of that period is, even for today. We obviously need some tweaking, but fundamentally, it really does give us some very good guide, and I would say it's the same for these. There are some things that we could debate, and hopefully we'll have time to do that, about what these criteria that are required to be fulfilled for waiver or alteration. But they consist of these factors. One, the research have to be impracticable unless you waive or alter the informed consent. And for the purposes of this discussion at this point, we're kind of assuming that kind of exists, right? Because I told you there's this tension. It has to be no more than minimal risk, and the waiver alteration doesn't violate rights and welfare of the subjects. And I'm going to skip the last one because that generally speaks to things like deception research. So the question is, let's start from the first one, the bolded one. Is the study minimal risk? Now, some people think that if two standard of care treatments are being compared, since everybody gets what the doctors would have recommended, inside or outside, almost by definition, that's got to be minimal risk. I disagree with that, and I don't think you can really answer the question without doing a case-by-case analysis. I've actually done a kind of eye-glazing, people get very bored when I talk about this, but I refer you to our paper. We've tried to formalize how you would go about assessing the risk of these kind of comparative studies, randomized clinical trials. And there is a very systematic way in which you can go about it. And I think we pretty clearly show that you have to do these case by case. But let's say intuitively, this is from another paper I wrote with a colleague, in which you can see, let's take this one, where you're comparing two FDA-approved anticoagulants in the emergency treatment of STMI. And the primary outcome is composite of some really serious clinical outcomes, like including death. You know, the potential side effects you're evaluating are bleeding, complications. The benefits are reduction in mortality and serious morbidity. And you can see there are several of those. There are surgical procedures and so forth that are being compared. All of these, in theory, could be considered standard of care treatments that are being compared in the clinical trial. I just want to appeal to you intuitively that you have to think long and hard about each case rather than saying, oh, they're both standard of care, so they've got to be minimal risk. Now, the other criterion is, would foregoing or modifying informed consent violate rights and welfare of subjects? This is a weird kind of legalistic criterion, isn't it? I've always found this somewhat difficult to interpret, but this is true. Rights could be referring to other existing laws or regulations. Maybe these regulations are saying, yeah, you know, you can waive or alter informed consent, but make sure you're not violating something else by doing that. That's a reasonable interpretation. But there is this odd mention of welfare given the previous minimal risk condition, right? So that seems redundant. So I propose that we interpret this to mean something like this, which I think is intuitive, is, you have to think about what people are otherwise entitled to in terms of rights and welfare, okay, rights and benefits. So here we come to the issue of reasonable expectations that are key. All right. And my point is that in terms of these reasonable expectations is that the precise reason why we want to do these trials are often because they involve preference-sensitive decisions by patients. We don't know which outcome is best, efficacy, but they have different side effects. Those are, that's what the entire movement about shared decision-making is about. So to try to change the consent in that setting would be kind of an odd thing to do. All right. I'm going to skip that, and I'm going to skip my slide on impracticability. It is actually a complicated notion, but it will take me more than 30 seconds. So I'm going to skip that. And I'm going to end with this final point. And this speaks to what Ray brought up. I do not believe that learning health systems, even though the word learning is much nicer than the word human subject research, it doesn't really erase fully the research-treatment distinction, and we can have a discussion about that. What it does do is it makes the ethical distinction more challenging to identify, but also, we shouldn't forget this, it pushes the tension to the very highest levels of organization, because the institution itself now wants to integrate. And there's going to be pressures to erase that distinction between research and clinical. And I think it's important that this gets addressed. It may end up being incredibly beneficial in the end, but we do need to look at that. Thank you.
Great. I'd like to thank everyone for really thoughtful and provoking questions and comments. I will invite anyone who's interested to please work their way to the microphones to ask any questions to our group. But I'll take the prerogative of asking the first question, and I'll address it to Professor Jacobson. In light of what we've heard this morning, I am having difficulty reconciling what is right versus what is practical versus what is allowed in the context of the pursuit of knowledge, whether or not we're calling it research. And I would love to hear your comments on that.
Thanks. Pleasure to be here. Thanks for a nice, easy question. You'll find the answer at the back of my next book. Okay. We just heard 3 absolutely first-rate presentations, raising lots of issues that pertain to that. And let me be clear, I don't have the answer to that question, and I'm not sure, as I listened to all 3, that we'd get much agreement on that anyway. But let me respond by talking about some things that I heard from this presentation. I don't want to call them the themes in a sense. First of all, what's the role of an IRB and / institutional control oversight with regard to all of the issues here? By way of background, I spent a little more than 20 years on the RAND Corporation's IRB, both as a RAND employee and then as an outside member when I came to the University of Michigan. And while I'm not a clinical researcher, I am a researcher. And while RAND doesn't do much clinical research per se, it did and does a lot of quality improvement work. And so a lot of the issues that we dealt with at the RAND IRB pertain to these kinds of issues. So the first issue is the role of oversight. The second is of course, the trust that pervades. How do we maintain trust? The third is around informed consent generally separate and apart from an IRB process. And so what are the common links here? First, choice. Who chooses? Under what circumstances? Second, how do we think about informed consent in a couple of ways? One analogy is to emergency preparedness. So you have an outbreak, let's say, an epidemic, or let's say a bioterrorist outbreak, and you quarantine. Let's just give it with an epidemic. You quarantine people. I'm sorry, I don't believe in quarantine, so I'm entitled to due process. But now we have hundreds of people who are quarantined. Can we have some type of collective due process so that people aren't detained improperly? I think the analogy is to the biobanks issue. How do we develop a collective informed consent process? Well, and then the oversight. I did miss one. A consistent theme here is the definition of risk. And that's something that pervades IRBs. So I'm not going to spend time discussing cases where researchers differed with the IRB on whether any particular intervention constituted more than minimal risk. Suffice it to say that there were any number of cases where researchers wanted to waive informed consent based on impracticability. You can't conduct the research. Well, that gets to the institutional control. I think, just two final comments on this. One is on the control side. It may be that IRBs are dysfunctional in some ways and inhibit research. But if we're going to replace them, we better replace that, sort of repeal and replace. We better replace them with something that makes sense, that does provide some level of institutional control. That includes, I think, Dr. Lantos, the issue of QI research. There's got to be some institutional mechanism protecting patients. We can discuss what that is, but my work on the IRB suggests that. The second is that while it's important not to overplay the horror cases that Dr. Botkin mentioned and the support trial, Kennedy Krieger, those are still warnings. They're warning signs that if we don't give patients some information, maybe the transparency issue, some information by which they can determine whether to accept the risk in the support trial of oxygenation levels, we do risk losing trust in the system. Final point, what about population health? How does all of this apply more broadly to public health? I think the clearest example, of course, would be the newborn screening. But as we talk about these issues, I think it's really important to see how can we bring in public health? How can we use this to improve population health?
Good morning. My name is Pat Reinvelt, and I run the National Network of Depression Centers. And one of our focuses is on employing these learning health system constructs to advance the research on depression and bipolar. Thank you for the thought-provoking presentations this morning. And one of the things that occurred to me as we were having this conversation about ethics is I didn't hear any reference to the Hippocratic Oath, which was one of the earliest ethical oaths that physicians took. And I was wondering if you could comment on how that's still applied or if it needed to be moderated as a part of this whole construct.
Well, most people who cite the Hippocratic Oath pick and choose carefully among its recommendations and its prohibitions, so that abortion, for example, is prohibited, surgery is prohibited. I think many people would have trouble with both those prohibitions today. Having sex with your patients has gotten to be even a stronger prohibition, so Hippocrates in modern times seem to be aligned on that one, but I think it's one of many codes. It was for, a particular time and a particular place, and has subtle meanings that may or may not be relevant today.
Yeah, I think it's a really interesting question about what the role of oaths ought to be within the system. And one of the interesting aspects of the research oversight system is that the regulations speak to institutional responsibilities and don't speak to responsibilities of individual investigators. So I think SACHARP has recommended that there be more attention to the whole notion of individual responsibilities, investigator responsibilies. I have a colleague, Aaron Rothwell, University of Utah, is working on the notion of a investigator's oath, where an investigator will explicitly proclaim his or her allegiance to a set of ethical principles in the conduct of that research. And the question is that meaningful for people? Do they want to have some sort of commitment to a set of standards? And will that change investigator behavior in any particular way? But it may well increase trust and confidence in the research system. We'll see.
And I'll address that with another question. So the concept of first do no harm is not technically part of the oath, but it's in many ways part of the spirit of where that's coming from. And I think a lot of the talks this morning were addressing what is and how do we define harm. And I will turn that question to Dr. Kim in relation to what you've been talking about in terms of practicality as well as implementation and understanding harm in that setting.
Oh gosh, I don't know if this is answering your question, but I can't help but notice that, like all good discussions about ethics in liberal societies, we keep coming down to freedom and welfare, harm, free, choice. So, that's the perennial tension. And honestly, I think that what we have learned over the years is that if you only look at harm or risk as your only guiding star in ethics, you're going to ignore other very important things. And especially things that happen to do with people's sense of trust, relationships, which require transparency, give and take, shared decision making. So I think that regardless of what the outcomes are, no matter how good the intentions are, you can't ignore that aspect of, what people expect. So I would just sum up. I think all three of our talks actually speak to that.
Just wanted to add that I thought these were absolutely great talks this morning. The ability to bring clarity to some of these issues is just fantastic, is really, really essentially important. My name is John Birch. I'm actually from Kansas City, although I don't really know John very well. I'm an angel investor, and I'm looking at opportunities to do something about some of these problems that make economic sense. And I want to just, I was at the AMIA conference over in Chicago the early part of this week. And couple points were made there, well, lots of points, but one in particular here. It's amazing the extent to which we are still prisoners of the past. And I think it may be true here as well. What I mean is this, that we imagine medical data in terms of electronic medical records. It's very clear to an awful lot of people working in that field that probably 60% of what is needed for medical decision making is not in the electronic medical record anyway. It's social and behavioral determinants, it's so-called psychosocial vitals, and so on. The sorts of things that 150 years ago maybe doctors really did have in their heads, the primary care docs that came to visit you, but it's not there today. So the objective is to try to find some way to collect that data and make it usable for medical decision making. To bring it back to the points here, one of the interesting things that I think is possible by the use of electronic data is to make medical decisions based on data that was never collected for any episode of care. Longitudinal pediatric-based care is one of the ones that I'm at least aware of, in which data that should be collected but usually isn't in gestational history and in the first 4 or 5 years of life are often very relevant to medical conditions that arise later on in life, and yet that data is never made available. How can we justify, cost-wise, collection of that data in the first place, retention of it for such a long period of time? It goes to the question that Dr. Kim was talking about, which is your wife you mentioned, was how are we going to collect all this data that we really want on patients, and how are we going to, you were talking about consenting them, but collecting data is in a sense a similar problem. I guess I just wanted to say, if we were to turn the learning health system on its head, instead of saying, what can we learn as a secondary use from data that's collected primarily for care, episodes of care, and of course all that comes from billable transactions. Instead of that being the primary use, the primary use of collecting data on patients is for research purposes. All 320 million patients in the United States. And the secondary use is for primary care, is for the use of that data. If we were to do that, how would that change some of these ethical kinds of issues as well? Thanks.
Can I just say one thing? I just can't resist saying this. We assume, I think part of what you're saying is the maybe limitations of electronic health records. And I just think that any electronic health record system that forces psychiatrists to make their depressed patients sound exactly the same from patient to patient can't be a good thing. And we accept things like that now. And I think we need to think long and hard about what it is that we're actually measuring with these existing or proposed electronic health record systems, because those are not really, I mean, any clinician in this room knows that EHR is not really designed to serve doctor-patient relationship. It really isn't. We know it's for other reasons. So, you know, it's something to really think about when we have this discussion.
I guess I'd just say don't put either one first or second, but think about systems that do both. I think the Scandinavian countries have the model for doing that.
We have time for one more question.
Hello. I really love hearing all of your views on everything. My name is Ann Dillon. I work at the IRB here at U of M. I'm a reg analyst. I've reviewed your studies previously, Dr. Kim. No, just as a disclaimer. And I wanted to know, I heard a lot about, talking about the opt-out concept for using data, using specimens, and kind of helping shift the culture of how patients are thinking about what happens when they come to the hospital and they give us information, because they do it all the time. And I was a bit concerned about hearing about how, using the institutional trust for people and having that kind of be a base for using specimens, using our data for whatever reasons there, and how does that really tie in with that notion of respect for people? A lot of what we're talking about here is this minimal risk research. I think we all agree if there's increased harm, like real harm, we want people to know. But for all this minimal risk kind of stuff, it's not maybe about harm, but it's about that respect. And like when you're in a study, what are you going to have to do? And when the institution is behind that, their interest is really the institution. It's not necessarily the subjects. The NCAA with athletes in the institution, the university works for the institution. There's no advocate for the athletes. Who's the advocate here for the patients, giving all of their data, and what does it really mean when they, when the institution is behind that versus a separate body really looking out for the interests of the people providing all the data?
I mean, I think respect for persons, honesty, transparency, and disclosure are the bedrock of any system that will earn and should deserve the trust of the people that it serves. I think the system we've set up now, where we make this artificial distinction between one set of activities that we call research and, in my view, over-disclose risks, and much larger set of activities that we call clinical care, where we under-disclose risks, doesn't have that requisite respect for persons, transparency, or honesty.
I agree with that. But one of the continual problems with informed consent is that it must be knowing and voluntary. And to some extent, informed consent is an oxymoron. You can have information, you can have voluntary consent, but how often do we have both? How often do patients really understand what they're being told, what the context is, how it affects them? And you expand that to the biobanks type of issue, where the use of the specimen is far in the future. And what are we telling patients and individuals? So I think that problem remains an issue regardless of how one addresses the institutional question.
Yeah, I guess I take your question as to be how do we actually implement a meaningful, transparent system? Because I think a lot of times institutions have their hearts largely in the right place in terms of how we set up some of these structures, but yet they're very poorly informed about what it is that the public actually might need to know. And I think the informed consent criteria, for example, that we're all familiar with, were developed by a number of very, very well-meaning people sitting around a table thinking, here's what we think people ought to be told, entirely independent of what it is that people themselves might actually need to know, and particularly around individual. So I don't have the answer. I'm sure there's people in this room who have thought much more about how to implement transparency, but obviously it has to engage the public in a much more meaningful way than putting a lay representative on the IRB and saying, we're good, we got public input.
I'd like to thank everyone for their attention and thank the panel for truly outstanding talks. We have about a 10-minute break and we'll reconvene. Thank you.